Hi, everyone, and welcome to the event, Healthy Hospitals, Healthy Planet. My name is Jocelyn, and I'm part of the NYU Langone Health, Energy, and Sustainability team. First and foremost, I would like to wish everybody here a happy Earth Day. I, along with our event partner, NYU's Office of Sustainability, are very excited to celebrate Earth Day with you all and with our esteemed speakers who are experts and complete powerhouses in their field. When I think of climate change, I think of health, the health of our planet, the health of our people and communities, and even the health of our economy. So today we are going to focus on the connection between health and environmental sustainability. We're going to talk about why sustainability is important in healthcare, how academic research can drive meaningful changes, and how hospitals are demonstrating that leadership. We have three speakers sharing their expertise today, followed by a brief Q&A. And to close off the event, we'll also be talking about the institutional sustainability goals at NYU and NYU Langone Health and the new 2021 Sustainability and Healthcare Database. I'm honored to welcome our first speaker, Gary Cohen. Gary Cohen has been a pioneer in the environmental health movement for more than 35 years. He has helped build coalitions and networks globally to address health impacts related to climate change and toxic chemical exposure. Gary is the co-founder and president of Healthcare Without Harm, which was created in 1996 to help transform the health sector to be environmentally sustainable and support the health and climate resilience of the communities they serve. So Gary, kick off the event for us.
Well, thanks everybody for joining today. I just want to provide a little context to the moment and the importance of what we're trying to do together here. This is obviously a really powerful moment in history, not only for our country, but for the planet. And in fact, it's an important day. What we're seeing is that all of the various traumas that we have experienced over the last long time period is coming together. So we're obviously in the middle of the trauma related to the pandemic. We're dealing with the collective trauma that we're beginning to understand and face around the climate crisis, and we're also addressing the intergenerational trauma of institutional racism in this country, our original sin. And all of these together are actually forcing a complete overhaul in the way we think about our health and our economy and our food systems, housing, democracy, preparedness. So it's an incredibly powerful moment on the planet. Now I'm having trouble moving to the next screen. Oh, that's why it's down here. Hold on a second. In the context of the broadest impact, climate change, it's impacting our health. Depending on where you live in the country, relates to what the impacts are. So obviously in the Northeast, it's extreme weather events. It's the spread of mosquito and tick-borne infections. It's increasing heat in places like Texas and Louisiana. It's flooding, it's hurricanes in the Northwest and the West Coast, it's wildfires. So all around the country, it's mental health issues, air pollution issues, impacts on food systems. It's ubiquitous. It just depends on where we are in our country and around the world in terms of what impacts are going to be felt more acutely. As we're seeing with COVID and the climate crisis, they are force multipliers for all the social, racial, and health inequities that we see in our society in terms of who's most vulnerable, who's most affected, who's most impacted, who will mostly die. And it's certainly people of color, the poor, people with disabilities, the elderly, and the youngest among us. This is not going to stop anytime soon, I'm sorry to say, but the climate crisis in particular is going to accelerate. And so we need to be prepared for that. We need to rethink a lot of the systems that we operate on to address this world in which we are growing into. Um, the core of the wound, I would say, at a climate crisis level is fossil fuel use, which has been the basis of our economy for a century at least, if not more. And new research that's come out of Harvard School of Public Health suggests that 8 million people died from fossil fuel pollution, air pollution in 2018. That means that 1 out of 5 people on the planet died from air pollution related to fossil fuels. It's an enormous figure, and that is a yearly figure. What's the role of healthcare? Well, the healthcare sector represents all the same contradictions of our economy that's built on fossil fuels, toxic chemicals. We did a research report with a company called Arup that looked at the global footprint of the healthcare sector, the climate footprint. And if hospitals and healthcare were a country, they would represent the 5th largest greenhouse gas emitter on the planet, 4.5% of global emissions. This slide shows that of that broad impact, United States healthcare is the largest share. So between the United States, China, and the European Union, that's more than half of all the greenhouse gas emissions for the entire global healthcare sector. So we in the United States have an enormous responsibility to address our climate footprint. Where does that show up? It shows up in energy that we use, in cooling, heating. It shows up in waste anesthetic gases, for example, desflurane, which is used in surgery, is 2,000 times more potent than carbon dioxide. It shows up in our fleets and our transportation. It shows up in our single-use plastics. It shows up even in the food we buy, especially industrialized meat. So there are many, many places in which there's room to change and act and decarbonize. We see the healthcare sector, given this intersection of all these different crises, as actually the central sector in our society that not only is holding the crises together, but also can be a leader in recovery, in healing for a broader societal transformation. So there's 3 fundamental roles. One is that we're trusted. Healthcare professionals are trusted more than any professions in America. Nurses are the most trusted, and then doctors, pharmacists, etc. And that role has been more elevated in the context of COVID as sort of truth tellers, as certain politicians have tried to confuse the public, deny the problem. The same politicians that are denying the severity of COVID are the same ones that are denying the severity of the climate crisis. We also have enormous influence. We're 18% of the US economy, 10% globally, so we can drive innovation. We can aggregate our power and detox our economy, detox our supply chain. Message to, if it's not healthy for hospitals, it's probably not healthy for schools either. It's probably not healthy for office buildings. So we can be an influencer. And then on the third is that we need to anchor the resilience of the communities we serve, especially in moments of crisis, whether that's COVID or climate crisis or other crises. So we did research with PricewaterhouseCoopers after Hurricane or Superstorm Sandy and looked at the impact at NYU Langone, which had to be evacuated. And we realized that the cost to the system was almost $1.5 billion because it wasn't designed for resilience in mind, for that level of disaster. It had to be evacuated, and the basements were flooded. The patients were evacuated. There was a 2-month suspension on surgery. There was an 18-month closure of the emergency department. Many providers sought privileges from other institutions. And so it had a huge wake-up call, not only for NYU Langone, but for the entire healthcare sector. In response, NYU Langone played an incredible role in redesigning, rethinking its facilities to bring combined heat and power. That means that if the whole grid in New York fails, NYU Langone can continue to operate. It brought in greater flood protection systems. It created a greater campus perimeter protection, a whole set of innovations around sustainable agriculture. And actually, somebody from NYU Langone, Richard Cohen, is going to be speaking about those resilience measures at our Clean Med conference. So it's designed now with climate change in mind. Very powerful. The way we see the kind of expanding of resilience is first, of course, you need to deal with your own infrastructure and supply chains. Then you can partner with others in governments and to assure that the systems in your community, in your city, are also climate resilient. That expands further out to address the social and environmental factors that are making people sick in the first place. The poor housing, the poor food, the violence, the racial inequities, the lack of people of color being locked out of good jobs, et cetera, the economic disparities. And then broader, that creates community health and resilience in the broader community. So the role of healthcare as the epicenter for that broader healing, that broader resilience is very powerful. As I mentioned, there's many, many places to take action. Reducing operating room energy use and waste, educating patients, developing climate risk plans, choosing more local and sustainable foods, doing more telemedicine. I think NYU Langone experienced within 3 weeks a massive increase in telemedicine that they would have expected 5 years. It would take 5 years to. So there's changes that can both address patients, address community, and address environmental footprint that are all positives along the way. NYU Langone is also part of a group of kind of leading early adopter healthcare systems that are driving the sector toward decarbonization. It's 18 systems that are working together to say, how can we decarbonize? How can we be better partners in resilience? How can we leverage our political power, our messaging to support policies that accelerate our transition away from fossil fuels? So there's a very powerful group of 500 hospitals that are all working together to learn together and to accelerate and short circuit the learning curve for healthcare. The impact, even among a small set of hospitals, 300 hospitals, shows that there's absolutely incredible amount of savings of waste, of water saved, of money saved, of lives saved by developing a sustainable path toward the operations and supply chain of healthcare. This was the results of only 300 hospitals. So you can imagine if all 5,500 hospitals were to embark on this sustainability path. The context is powerful. Today is Earth Day. President Biden just made a speech that he's committing the US to a 50% reduction in greenhouse gas emissions by 2030 and zero emissions by 2050. There's a whole set of cities and businesses and investors and now hospitals and universities that are all joining that effort to move toward a zero emissions healthcare and economy. And so doing that in a way that creates jobs, creates innovation, unlocks sustainability in communities that are served by these institutions is an enormous opportunity, and something that we hope that many of the hospitals in the Healthcare Climate Council follow suit. I'll mention one important initiative is there's ways in which we can move, leveraging our investments in healthcare, leveraging our purchasing. This initiative, Anchors in Resilient Communities, is based in the Bay Area in California, but it leveraged Kaiser Permanente's commitment to 100% local and sustainable food to then provide guaranteed markets for sustainable growers in the area, provide jobs to people in the community. And the result is a $20 million food processing center that can provide sustainable food to people for hospitals, for schools, for medically tailored meals, for people that are hungry. So it's a way to start to reweave systems in our communities that can address those upstream factors that, in fact, are leading to the epidemic of chronic disease that we see in our society. NYU Langone is right in there. We have a healthcare culinary contest, and one of your chefs was a finalist. NYU Langone is also participating in supporting farmers markets and supporting more sustainably sourced products from diverse suppliers in the region. So you're in that story and sort of seeing food as medicine and modeling the kind of healthy food environments that we need in our society. On the advocacy side, because of health, because of the powerful role of nurses, we see to elevate them, to educate them, to become those messengers for climate change and health and a sustainable economy. So we've got a collaboration with a group called the Alliance of Nurses for a Healthy Environment to educate and activate 50,000 nurses around the country. NYU Langone's, NYU Rory Myers College of Nursing is part of that. There's 30 schools of nursing now. They're trying to educate the next generation of nurses to be these leaders and advocates in their institutions and in society. You all have a treasure in your midst. Cassie Thiel, who's going to be speaking a bit later, is doing really important research around clinical sustainability. There's others like Jonathan Gross and Rebecca Florsheim who are also doing that, but it's a crucial role that healthcare academic institutions can play to drive change. I'll give you one example. I'm almost done. Just recently, NYU Langone Health showed that exposure to toxic flame retardants early in pregnancy can be linked to premature birth. And so that's one of those chemicals that we're trying to get out of hospitals that are in many furnishings, getting out of schools, getting out of the economy. And so having that kind of research that validates this very crucial impact has incredible power for us to then move an advocacy agenda to get it out of the economy. In the end of the day, healthcare is an incredibly powerful agent for both public and planetary health to leverage all of its assets, its ethical, economic, and political clout to play a fundamental role in changing society. Martin Luther King said, you know, the arc of the moral universe is long, but it bends toward justice. But that only happens if we do it together, if we bend it together. And I'll end with a whole boatload of resources that can help people who are listening and watching to get involved in this movement. We need you, we need everybody. So thanks very much. Look forward to hearing what others have to say. Thank you.
Thank you, Gary. I think you did a really great representation on how sustainability really touches upon not just operational efficiency, which is what often people think about, but it's also about equity, resiliency, and ultimately what's the health for our communities. So thank you for that. And for next up, I'm like to welcome Dr. Leonardo Trasande. Dr. Trasande is an internationally renowned leader in children's environmental health. His research focuses on identifying the role of environmental exposures in childhood obesity and cardiovascular risk, and documenting the economic cost for policymakers of failing to prevent diseases of environmental origin in children proactively. Dr. Trasande is a member of many national cohorts and serves on multiple scientific committees and expert panels on environmental factors on children's health. Welcome, Leo.
Thanks for having me. My comments really dovetail very naturally with those of Gary's, and it's a privilege to be here with you. So my work focuses on synthetic chemicals that scramble our natural molecular signaling. They're called endocrine disruptors. Endocrine refers to hormones. Hormones are our basic signaling molecules underlying everything from maintaining a healthy body temperature, good metabolism, salt, sugar, even sex. And we have rapidly increasing evidence that synthetic chemicals, including those used in healthcare settings, in products, substantially scramble those molecular signals and contribute to disease and disability across the lifespan. We know of at least 1,000 synthetic chemicals that do that. We don't know all of the chemicals that do that because we don't routinely test many chemicals for their effects on hormones in our bodies. The evidence is particularly strong for 5 categories of chemicals. One, Gary already highlighted, flame retardants used in electronics and furniture. Phthalates used in personal care products, cosmetics, food packaging, and even substantial medical devices, including, unfortunately, even the newborns in the newborn intensive care unit who have substantial exposure out of proportion to their body weight. Bisphenols used in aluminum can linings and thermal paper receipts. Pesticides used in agriculture, and a new category of chemicals, new for some, perfluoroalkyl substances, or PFAS. They're used in nonstick cooking and oil and water resistant clothing. They're called forever chemicals, which is important because they're the basis also of a movie recently out by Mark Ruffalo called Dark Waters. But these chemicals have a host of consequences. They contribute most substantially to the effects on the developing brains of young children because they disrupt thyroid hormone. Particularly the flame retardants do that. And thyroid hormone is crucial for a baby's brain development. Baby requires mom to have a healthy level of thyroid hormone because the baby doesn't make thyroid hormone until the 2nd trimester of pregnancy. And even in the clinically normal range, effects on thyroid hormone can have consequences not just for cognitive function, but for even clinically significant sequelae like autism and attention deficit hyperactivity disorder. We know of 50 or so chemical obesogens, chemicals that literally make us fatter. One paradigmatic example are the PFAS. They literally turn the body's thermostat the wrong way and were associated with decreases in resting metabolic rate and weight regain in adults who had lost weight through healthy diet and good physical activity. So nothing I'm saying here today undermines the importance of good diet and physical activity in contributing to maintaining a healthy body weight. But we know that synthetic chemicals can scramble our molecular signals, and the phthalates, for example, can shunt calories in the body from protein or making good muscle to lipid and carbohydrate metabolism. The bisphenols change how the body decides to program stem cells such that they become fat as opposed to bone. And so we have substantial evidence of multiple obesogenic and other adverse imprints for cardiovascular health. We also know that fertility is decreasing. Sperm counts are on the decline. We know that a host of conditions such as endometriosis and fibroids affect all too many women. And chemicals such as phthalates, the PFAS, and the others I've mentioned have been directly identified, not just in the laboratory, but in human studies to impair reproductive function, contributing actually to delays in pregnancy and even, as importantly, decreases in testosterone levels in adult men have been not just tied to potency or fertility, but low T is a marker for or predictor of adult cardiovascular disease and even stroke. And phthalates disrupt testosterone function, have been directly tied to 10,000 US deaths in adult men annually. So these have societal costs, and Gary's already alluded to some of the large costs of climate change due to fossil fuel production and consumption. And there's commonality and actually some overlap in the Venn diagram with endocrine disruptors, which I can get to as we wrap up. But the costs of these exposures have been identified in the US due to endocrine disruptors to be $340 billion, that's billion with a B, dollars each year. That's 2.3% of the US gross domestic product. And that's an annual cost insofar as exposures continue at current levels. And yet that was based on less than 5% of known endocrine disruptors, subset of diseases due to the few chemicals that we studied, and a subset of costs due to the few diseases due to the few chemicals we studied. So 2% of our gross domestic product is an underestimate of an underestimate of an underestimate. So literally the theme of this my talk today is that chemicals are literally making us sicker, fatter, and poorer. And ultimately, we have to lead as healthcare facilities in mitigating and minimizing exposures. We know that these exposures can rapidly be mitigated. You substitute a family's diet and remove food packaging and canned food, and you rapidly, in days, reduce bisphenol and phthalate levels. The same is true for pesticide levels through eating organic. In households, study actually supported substantially in our group here at NYU in the Center for the Investigation of Environmental Hazards found that an intervention to reduce to replace furniture and furnishings with healthier materials substantially reduced the PFAS, flame retardants, and an emerging category of flame retardants that may be as problematic as the older brominated flame retardants called organophosphorus esters, or OPEs. So we know that interventions can be styled to work, and given the substantial costs to the economy of diseases related to these exposures, there are potentially net societal benefits, even if the interventions do pose a cost to healthcare and other facilities. So how can healthcare facilities lead? And that's going to be my hopeful comment. We've seen them already lead in reducing exposures in the newborn intensive care units. Hospitals have gotten together and identified and insisted on upstream manufacturers to provide phthalate-free medical devices and other materials and identifying safer alternatives. Nothing I'm going to say today minimizes the importance of medical devices and the need for some of these chemicals, but we really need to minimize whenever possible and reduce unnecessary use of these products in particular. So in regards to food packaging, simply using less plastic, period. We've gotten into a bit of a weird spot with the pandemic. There has been this assumption that droplets on surfaces are a major transmitter. Now, for harder surfaces, there's some science suggesting that the particles can persist. And there might be some reduction in transmission through fastidious cleaning with soap and water. Harsher cleaning chemicals don't appear, however, to really have much in the way of impact. But one other way we've gotten lulled to sleep is we've seemed to have been had plastic pushed on us as a safer alternative to glass and stainless steel and other reusable materials. And the notion that those actually reduce COVID transmission is just not really supported by substantial science in any way. And we've seen a rapid rise in the use of plastic since the pandemic began, and that has a double consequence, not just chemical exposures increasing in people who use these products particularly, but also in the legacy of plastic and other wastes that have skyrocketed during the pandemic. And I'll close with one final thought is, I hinted at many of the endocrine disrupting chemicals I'm talking about have their origins in byproducts of fossil fuel consumption and production. Now, I'm not going to say that curing climate change will also cure endocrine disrupting chemicals by itself. There are co-benefits though. At the same time, I argue very strongly that the endocrine disrupting chemicals may well be the second greatest environmental health threat in our time. And the argument I'll make is that yes, if we cool the planet, we will have perhaps gotten past one problem, but if we leave behind generations who are substantially exposed to chemicals that threaten our fertility as well as our health, we will not leave the world in a better place than we entered it. Thank you very much.
Thank you, Dr. Trasande. Your work is incredibly important. And like you mentioned, these are proponents that aren't visible to us, but exist in everything that we touch, we eat, in the environment that we live in. So it's really important to kind of keep that in mind, especially as individuals who are making choices in what we purchase. So last but not least, I'd like to welcome Dr. Cassandra Thiel, Cassie is an assistant professor at the Department of Population Health and Department of Ophthalmology at NYU Grossman School of Medicine. Her research utilizes life cycle assessment and principles of industrial ecology to analyze and improve the environmental performance of infrastructure systems, hospital design, healthcare practice, and medical technologies. Welcome, Cassie.
Yeah, so as Jocelyn said, a lot of my research is really focused on the environmental footprint of medical practice. Oops, let me make sure everything's loaded up here. All right, good. You can see everything, hear me okay? I'll double check with Jocelyn, great. All right, so yeah, my lab at NYU is really looking at medical practice and how we can make that greener. So it's kind of specified into one particular zone. What I like to tell my students is, if you're worried about sustainability in the planet and health, there's just too much that you can worry about, right? You can't tackle everything. So you should focus on the one thing that you're passionate about and trust that other people are working on their sections. And so I think Gary gave a really nice overview of all the different areas of sustainability that need to be tackled and addressed. And Leo's work is really important. And so here I'm going to talk a little bit more about healthcare practice in particular and what kind of research we've got going on in the field. So just to kind of get you all warmed up a bit, I've got a few questions just to get you thinking about healthcare practice. I know some of you are clinicians, some of you are medical students, but some of you may not be that familiar with medical spaces. So this is just, have you worked in an inpatient unit? Have you been in an inpatient unit? Have you been in a surgery? There's a lot of things that happen in a surgical, in the operating room. But all of these services that we typically think of with medicine actually need a lot of other services to keep them functioning. And so some of them you might think about supply rooms, right? We have to have a lot of products and materials that come into our hospitals. We have supplies that are actually reused, and those get sterilized in a place called central sterile. Typically it's in the basement of most hospitals, but this is a whole other process that requires its own inputs, water and chemicals and energy to keep those supplies sterile and safe. And then of course we generate a lot of waste. So all of this garbage that we make has to go somewhere, whether it's kind of liquid waste from laboratories and testing facilities, or it's solid waste. It might be this red bag waste you see here that's somewhat hazardous. It could be infectious if people interact with it inappropriately. We have laundry in our hospitals, right? So all these linens have to be cleaned somewhere and sent back to the hospital. Those supplies that we talked about, the garbage for, they have to be manufactured somewhere. So there's a lot of raw materials that are extracted from all around the planet. They go to different factories also all around the world, and they get packaged together. This is actually a plant based in Chicago where they're wrapping up what are called custom packs. So these are all sterile supplies used for surgeries, and these will be shipped out across the country. And then even further downstream, so going back to the other end of this supply chain, all that medical waste has to be treated and disposed. This is a waste incinerator in India, but all this garbage ends up somewhere. Usually in the US it's in a landfill, but it could be an incinerator, and there could be other treatment steps. Every step and stage on this has a footprint. We're releasing chemicals to our environment, we're releasing CO2 and other greenhouse gases into the air. And all of these things play a factor in the footprint of healthcare, which is fairly substantial. And so when you're trying to address sustainability in a system, you have to think about how the system works. What are the inputs? What are the outputs? What are the processes in place there? So I'm going to pull up a slide that you've actually already seen through Gary's work. This is one I stole from Jenna Agins, our sustainability coordinator, and I suspect she stole the base image from Healthcare Without Harm. So there's some really good resources out there if you'd also like to share these things. But the basic takeaway here is a hospital is almost like a city in and of itself, right? It's not just the medical practices going on, the procedures and things. We're feeding people. We have cafeterias and kitchens. We're generating power. We need electricity and backup generators. In our case, we actually have a cogen facility that's generating steam and electricity as part of our resilience strategy after Hurricane Sandy. We have supplies and patients coming in and out. There's a lot of logistics, and all of those supplies, all the energy coming in has to be manufactured somewhere. And then, of course, downstream, it all has to be disposed of properly. And so just NYU Langone, you can see some of our stats there without Winthrop. I probably need to update these now, but we're a huge facility, and we're not the only facility, of course, performing healthcare activities in this country or even New York City. So you can imagine how big the footprint can be for these hospitals. There's a lot of things happening. So when we're talking about potentially mitigating these impacts, we have to think about where are all these impacts coming from? We have to understand that. And that's where my research comes in. So this tool that Jocelyn mentioned is called life cycle assessment. And we're basically looking at the life cycle of all of the products, all the energy that are needed for surgeries and other procedures. And we're quantifying the emissions associated with each step and stage, right? So those products are manufactured, that has emissions. They are transported to the hospital, that has emissions. The hospital uses them, that has emissions. And we sum all of those emissions up into a single number, so we can get things like a carbon footprint. And we can also understand then where a majority of those emissions are coming from. Outside of the healthcare sector, this also lets us compare different products more evenly to prevent greenwashing. I don't know if you've all heard of greenwashing, but you would have experienced this anytime you go into a grocery store or any kind of commercial setting, right? There'll be labels on products and you don't quite know what to make out of it, right? It's organic, it's green, it's, I don't know, sustainable in some way. But without having hard numbers to validate those claims, it can be really difficult for you to understand what that even means, and really easy for companies to just say it's green without any validation whatsoever. So life cycle assessment gives us those hard numbers where we can compare products and then also look for weaknesses within our own system where we can improve things. And we need a lot of data to do these life cycle assessments. And so this is one of my very first forays into healthcare. We were looking at hysterectomy at the University of Pittsburgh Medical Center with OB-GYN physician named Noe Copley-Woods and my PhD supervisor, Melissa Billick. And we wanted to better understand where the footprint of surgeries lie. And so we went into these hysterectomies, the removal of a woman's uterus, and we looked at all of the garbage that's generated, and we used that to kind of estimate what comes into the surgeries. So here we have a very intrepid undergraduate student helping us sort out waste. And we divided it out by the types of materials that were there. And we were able to actually then quantify the environmental footprint of this procedure. But we dug through a lot of garbage. And the fun thing about waste audits, you may not think they're fun, but they're actually very interesting. You get a good feel for what's going on in a system when you're really digging through their garbage. And that's true in healthcare, and it's true in your home. It's true wherever you want to do a waste audit to better understand what's happening. You get cold hard facts you can't deny. And so here you can see a few things in the picture. In the foreground, of course, there's a bunch of gloves. You imagine a surgery, we're using lots and lots of gloves. And just to the left of those gloves, there's a couple of canisters. Those are for fluids coming out of the surgery, but you can see they're absolutely bone dry. It's because they weren't used. And so a lot of these things, were new to me. I had never really been in an operating room before, but watching it from an engineering kind of perspective and then digging through the waste and learning more about it, I realized that there's a lot of room for improvement in surgeries. So some of the things that we were seeing, sorry, that one picture is rotated on the right there, but one of the things that we were seeing, of course, was a lot of products that are actually fairly complex and maybe quite valuable, right? Not just cheap plastics that are easy to dispose of, but in healthcare, we see a lot of stainless steel instruments, a lot of complex kind of electric components, and these are all single-use and disposable. So there's a propensity in healthcare to dig into single-use disposable products. And this, of course, has a larger footprint because you have to manufacture these things every single time you use them. And then throwing them out, you're not recovering any of these resources, which is a little bit sad. That picture on the right there is actually a robot, so the surgical robot, and it has attachments that are also disposable. So there's a lot of waste coming out of operating rooms in particular, but kind of all healthcare, and it's not just simple plastics. The other things we were finding from the waste audits that were quite interesting, first was batteries, literally AA batteries, just the same old batteries you find in your house. And there was about 6 to 8 of these in 2 of the types of hysterectomy, the laparoscopic and the robotic cases. So 6 to 8 batteries in each case that would be thrown out after about 2 hours of use. That's a lot of energy that we're wasting. We found reusable items that were not supposed to be thrown away, but would accidentally get wrapped up in the drapes and thrown out. And that's a lot of money for the hospital. Like this cup could cost upwards of 10 grand. Pricing is a little unique in healthcare settings, but this cup was supposed to be used for a really long lifespan, and now it's accidentally thrown away. And then the last thing we found a lot of, which I kind of alluded to in that first picture, is unused, unopened items. So anything coming into a surgery typically has to be thrown out, even if it's not used, even if it's in its own sterile packaging like this. And this is interesting regulation that, there's a lot of complication here in this clinical space about what's the safe thing to do, what's the right thing to do. But these unused, unopened items is just a glaringly obvious area where we can improve things. And this is something that other researchers have also been finding. So this is one of my favorite studies out of, I think it's University of California, San Francisco, but it's out in California regardless. And basically these researchers had gone into their neurosurgical cases and looked at all their supplies that they were throwing out unused from their surgeries. And across their department, they estimated about 13% of their supply costs were just these goods that were not used at all. So if they could somehow prevent that waste from occurring, if they could just get rid of those items before they were brought into the operating room, they could save almost $3 million a year in this single surgical department. This form of waste is huge, and it's one of those things that's just an easy win in that the hospital, would save money, and we'd also, of course, reduce the footprint from manufacturing and disposing of all these products. We'd essentially be increasing the value of care. So to get back to the hysterectomies, this is the first study, so you can see how we presented the results is a very engineering approach. So this is usually where a lot of people glaze their eyes over. They don't like graphs, but we were looking at more than just greenhouse gases. And each cluster here, there's 4 bars to represent the 4 different types of hysterectomy that we were looking at. So you have abdominal, vaginal, laparoscopic, robotic, and each grouping is a different type of emission. So that first one is ozone depletion, right? If you were a child of the 80s, you would have heard a lot about the hole in the ozone and how we need to work to close it. We're still emitting things that are affecting the ozone. And so we can measure that with life cycle assessment. That second grouping is greenhouse gases. Of course, climate change, the big one. And then kind of running quickly through the rest of them in case you're curious, we have smog, acidification, eutrophication, those are water issues. Carcinogenics and non-carcinogenics are human health issues, which is why they have really large error bars. Then we have respiratory impacts, ecotoxicity, and cumulative energy demand. And so if we were in person, I would be able to stop and kind of quickly scan all of you and see if you're too glazed over or not. But you can see the different colors here. And I would usually ask, what do you notice from this? And some of the big takeaways typically are that, well, one, those laparoscopic and robotic cases typically have a much higher footprint than the abdominal and vaginal cases. You can see that those bars are much higher. And basically, the more complex the case is getting, it hasn't saved on our resource use. We're actually using a lot more resources to utilize these more high-tech surgeries, which is kind of unfortunate. The next thing that people usually notice is just how much green is on this graph, and that is the production of single-use supplies. And the reason I like to highlight that is because a lot of people focus on the downstream when they're talking about their clinical care. You know how much garbage you make, you know that garbage is going to end up in a landfill and it's bad. But a lot of the emissions are actually coming from upstream impacts, from how those things are all manufactured. And that's something a lot of people don't realize, that you have to think about this whole life cycle, because it's not just about the garbage, it's about all that upstream stuff as well. We got a little bit better with our graphs moving forward, but I've worked with cataract surgery. So this is an approach called phacoemulsification. And we were able to compare the United Kingdom, that's the bar on the left, with a place in India, the bar on the right. And this particular place in India is very high volume, very efficient. They're designed to reduce the cost of care so they can care for the world's poorest patients. And as a result, they've actually reduced their carbon footprint substantially. It's about 5% of the carbon emissions from the same procedure in the UK, and their outcomes are actually just as good, if not better. So it's at least in cataract surgery, it doesn't appear to be an issue of infection control. You can do this very well and very efficiently. We're not just looking at cataract surgery. We've got a whole bunch of other projects. This is looking at interventional radiology with Dr. Jonathan Gross at NYU Langone. So we went in and monitored all of the interventional radiology procedures for a week. And this is kind of where we saw the emissions coming from. HVAC is heating, ventilation, air conditioning, it's energy. And then, of course, the production of single-use supplies comes up again. So we're seeing quite a bit. Then we've got inpatient units. This is an ongoing study that's hopefully going to be published very soon. And here we compare some of our intensive care units and kind of normal intensity units here in the US to the same kind of approach in the UK. So you can see we actually generate a bit more than the UK does. And our intensive care units have more emissions than the regular inpatient units, which kind of makes sense if you think about resource use there. We've looked at biopsies in a surgical pathology lab. The emissions here are very small, but we run a lot of labs. You know, there's a lot of biopsies conducted every year in the US. And so cumulatively that adds up. We've even looked at non-clinical areas like our kitchens. Here's Jocelyn helping out with the waste audit. We wanted to see how composting might work and kind of estimate how much we could save there. So we did some really fun stuff in the kitchens. But basically, all this research is supposed to help us, figure out what to do with our surgeries, with our clinical areas, with anything related to a hospital, and what approaches might be best to reduce our footprint. Right? We can invest a lot in recycling, but as this figure shows, recycling only saves 1% of our carbon emissions. So if you're going to spend a lot of money and human resources on interventions to reduce your carbon footprint, you should probably try to target them at things that will have a really big impact. So in this case, this is looking at laparoscopic surgeries, reducing what you're bringing into the surgery by getting rid of all those unused items and optimizing your instrument tray really has the biggest footprint. We're also developing tools for providers. So this is for cataract surgery in particular. We've got an app called iEfficiency that people can take into their surgeries and actually monitor what's going on, and it'll calculate out their carbon footprint, their productivity, and their costs. So there's a lot of value to having all of this information. Basically, in healthcare, we're looking at a systems issue, right? It's not, my approach is not the only approach for dealing with this, and it's certainly not the only way that we need to look at this problem to address things, right? We have payment and reimbursement issues, there's contracts, the training that goes on locally, there's policies and regulations and travel, and just a bunch of things that are kind of coming together. So we really need everyone's thoughts and ideas on how to fix these issues. I advocate that data can help, but it's certainly not the only solution. And I will skip really quickly over this because I think Jocelyn's going to talk about this, but they've developed a really nice database of a bunch of different studies that have been conducted in this area of health and sustainability. And I think it's really great resource for people who are curious about what they can do either clinically or outside of their clinic, how they can think about the ways in which pollutants and climate change might impact their patients. And what other kinds of actions outside of just research we might take to help mitigate our footprint. So there's a lot of cool things out there if you're curious to learn more, and I'll end there. Thank you so much.
Thanks, Cassie, for sharing. We've had the pleasure of working with you several times on many projects. And as you see from that picture, I was also very excited to dig through trash. So
it's quite fun.
It is pretty fun. So right now we're going to go to our Q&A and kind of talk through any questions we have for our panels. And to kick off, I think what we should talk about is generally for any of you speakers here, what are some innovations or demands do you see in the near future when we talk about environmental health and sustainability? Do you see an increase of demand for policies, innovations in operational management, or is it a surge in industry knowledge in pushing this work forward?
Well, I'll just quickly say, healthcare without harm's goal is to aggregate the power of all these systems, NYU, Langone, and so many others, to drive the marketplace and drive policy toward low carbon healthcare, toward toxic free healthcare. So if you take the example of the flame retardants, we organized hundreds of hospitals to demand furnishings for their facilities without flame retardants. And so in the course of a few years now, we've created $700 million of demand, which is a lot. So the manufacturers feel like they need to respond. So I think there's a combination of market transformation, and there's a combination of some policy initiatives that, if implemented, would drive everybody in the sector toward these strategies. I think what Biden has done today is to set a marker that say, look, this economy is going toward moving away from fossil fuels. And so we're going to have healthcare play a fundamental role in driving that within the context of healing, within the context of health. No other sector has to be able to say, has the opportunity to say, when we do these measures, we're actually going to improve people's health. It's such a powerful story to tell.
Yeah, and I would agree. I think it's not one or the other with all of these solutions. We kind of need all of them. There needs to be policy changes. There needs to be this ground up kind of, I guess, innovation on what works for different systems, what doesn't work for different systems. We need action at all levels. So whatever you're passionate about, you should just dive into.
And I would just add that I see healthcare organizations increasingly taking that with gusto as incentives increasingly are aligned with community level health endpoints as well. We know that these exposures impair human health, and insofar as it hits healthcare organizations' bottom lines, even if they're longer latency outcomes, if it hits the bottom line, it will bubble up and ultimately bubble up all the way into driving the change we seek. We've seen this time and again that manufacturing practices and corporate practices change when purchasers insist on the change. And if you align all the incentives upstream and downstream, you can get virtuous systems that can work also on behalf of environmental protection and human health at the same time.
Absolutely. I do see a question from our audience. It's from Amanda. There has been a big push towards value-based reimbursement in healthcare. Do you see a role for incorporating minimizing procedural waste generation into initiatives meant to decrease the healthcare costs and increase the quality of life delivered? This one is probably for you, Cassie.
I would say yes. Yes, I think there's good areas to kind of fix this. We're seeing so much waste in healthcare, and there needs to be some incentives for addressing that. And I know a lot of my colleagues kind of in this field really want to see quality metrics include things around resource utilization and being more efficient on that realm, if not also carbon emissions directly.
And I think, listen, healthcare needs to move upstream. It's like we've learned over the last 25 years that it's the conditions that people face in their communities, in the places where they work, in their homes. Those are the things that are contributing to chronic disease, as Leo was saying. So we need to kind of change the incentive system so that if people are hungry, we feed them, and that will prevent disease. And if we feed them good food, we can prevent heart disease and obesity and diabetes and strokes. If people have poor housing, let's improve the housing. That will reduce the asthma triggers that bring kids to the emergency room all the time. If there's massive air pollution, let's get off of fossil fuels in transportation and energy, because that'll reduce all these other health impacts. So we have to move upstream, like as opposed to seeing healthcare as the last stop, sort of cleaning up after an economy that's actually manufacturing disease. Let's build an economy that puts health and equity at its core.
Absolutely. So, this question is something that you've all already have touched upon in some sense, but I do think it's really important to emphasize, especially given what we've seen a lot in the last year aside from COVID, but earlier of 2020, there were also large wildfires in Australia. In the US, there were a massive social movement that we've seen throughout the entire summer and still continuing today. So I would like to, for any of you to kind of talk through which groups and what communities are most vulnerable when we talk about chemical exposures, when we talk about more frequent extreme climate events with air and water pollution. And we'll only be able to see this exacerbate over time. So I would love for either any of you guys to elaborate on that.
I mean, it's pretty clear that the poor and communities of color have been targeted for the most polluting industries, for the diesel transfer. If you look at where pollution is and you look at where racial disparities are and you look at where health impacts are, they're coincident. And so part of what we need to do in leveraging all of these assets of healthcare is to also address the racial injustices that we face. And healthcare is in a great position to do that through its contracting with more BIPOC farmers, BIPOC contractors, targeting some of its community health programs, its investments in places which have been locked out, which suffered these impacts. So I think we need, what have been called the social determinants of health and healthcare is really a kind of antiseptic way to say the communities of color in many cases and poor communities. And so we need to address those as part of our healing mission.
I would just add that environmental factors are a big driver of health disparities. We talk a lot about healthcare delivery, and I'm not trying to minimize racism, but racism takes many forms. It takes the form of products that are sold to people. It takes the form of what food options are available, whether processed or packaged foods are the norm, whether organic food is even remotely available, let alone the price differences. And we've done a series of studies documenting that African American and Latino populations disproportionately share the burden of disease that I talked about at the top due to endocrine disrupting chemicals. So I wholeheartedly agree. I just want to put an extra point of emphasis that when we talk about social determinants of health and when we talk about racism, it's not just socially driven racism. We've known about environmental racism from Anniston, Alabama, from PCB dumping, from, in the South Bronx. We saw all those, all the trucking companies and oil delivery and consumption facilities being placed there. We know where coal-fired power plants are placed. So this is a history that reverberates again and again. The populations that are less well able to cry out are the ones that suffer and then go to our healthcare facilities, and our healthcare facilities pay ultimately for their care, or perhaps earn some funding for it. But the reality is that we as healthcare providers really need to cry out and speak out about that. And if it hits our corporate bottom line, ultimately in the form of what we receive, if we are responsible for the health of a population and get paid on a capitation or whatever basis, that I think will start that virtual circle. And as Gary said, we need to drive this upstream change so that it's not just at the end where people are hitting the hospital or the ER or what have you. We have to work all the way back towards primary prevention.
I agree 100%. I also had the global perspective with climate change, and just like our supply chains and things are very global, right? When Hurricane Maria hit Puerto Rico, we did not have IV bags. And that's something that's going to become more and more common. We certainly had issues when COVID hit with PPE because of where that was largely manufactured and where those supply chains are located. So it's not just necessarily a local issue. This is also there's global implications for this as well, with climate change, that it's also going to hit poorer countries, and that's where we've located a lot of our manufacturing. And so there's a lot to consider on that front.
So I have one last question for this group, and I love to focus on individual stories. And one of the challenges I think with climate change when people think about it is that it's a big picture issue, and that individual action, and like how can my individual action create a positive impact? So, what are individual actions you have taken when you were younger and just starting to think about sustainability and environmental health? And how did that lead to where you are today, now impacting and creating this positive impact on a local and even global level? Leo, do you want to kick us off?
Sure. This is really right up my. I mean, there are safe and simple steps we can take to limit our exposure to endocrine disrupting chemicals. And there are other downstream benefits along the lines of what Gary and Cassie have talked about already. Just saying no to plastic. Quitting plastic would be ideal. I mean, I'm actually going to be making a video pledge to quit plastic by 2040. It's going to take some time because there's a lot that we have to fix. There are people who've actually done it, by the way. But if you go into my household, you see very little plastic at all, only for the few times where my kids have to take certain products out and the school insists that they can't be in glass for shatter and other reasons. But stainless steel is a great option. If you must use recycling plastic, please avoid the numbers 3, 6, and 7. 3 is for phthalates, 6 is for styrene, a known carcinogen, and 7 are for the bisphenol. Certainly don't microwave or machine dishwash plastic, and because that erodes this notion of microwave safe plastic is quite flawed. That's only at a macroscopic level, not at a microscopic level. Eating organic, we've come a long way. I work at Bellevue Hospital. 10 years ago, I wouldn't have suggested it routinely to patients, but we've seen market share explode and price margins have started to flatten, such that the big box stores are putting it out there. Certainly the ones you can prioritize are the leafy green vegetables, where the pesticide residues are the greatest. And, as Gary said, it doesn't necessarily have to cost money or require a PhD in chemistry to do any of the things that I'm talking about. You just look at the label now. California now requires flame retardant disclosure on new pieces of furniture you're buying. And there was no change in price when the California law for flame retardants changed. And it simply was a change that was made at a broad consumer level. We saw it even earlier with BPA-free in baby bottles and sippy cups. It wasn't science that drove that change. It was moms crying out, "What the heck is this in my baby bottle?" And they ran to the companies. The companies sprinted to the FDA and said, "Please ban it." And all of a sudden there was a ban on BPA in baby bottles and sippy cups. So we've seen this kind of consumer change be that change we seek on many levels, and not many of the changes at all really require a PhD in chemistry or have to break the bank.
Well, I certainly don't have a PhD in chemistry. My biggest change that I could say is that I come out of the environmental health and justice movement, and I was working with communities all around the country fighting incinerators. And in the mid-1990s, we learned that hospitals were the largest source of dioxin emissions in the country because of all the medical waste they were burning, and a significant source of mercury because of all the broken thermometers going in the incinerator and going out into the environment. And it dawned on me and others saying, how are we going to create healthier society if the very sector that has healing as its mission is itself an enormous polluter? And that was the impetus to start Healthcare Without Harm. I'm not a doctor. I studied Indian philosophy in school. So, but the way that this has been taken up by the health sector in this country and around the world is so gratifying. There's a global movement now in this regard. And so, my goodness, taking any person where they sit in any institution, as Cassie says, and find the thing that's passionate and make a change in that space, in that place. There's an opportunity to lead from any seat. So that's my story.
Yeah, I'd say the same. I got here through engineering. This is an interesting pathway. But you'll develop different skill sets as you go, and whatever those are, they'll be valuable in the sustainability mission, right? We need all voices and all different lenses, perspectives. So if you're a clinician, one of the things I talk about there is, think about your sphere of influence. You may not be able to make NYU Langone get rid of all their plastics. I think that may be unreasonable, but you could talk to your surgical team and say, don't open products unless I tell you to open them, to try to prevent that unnecessary waste. There are little things that you can do no matter where you're at that will have a footprint. But I think the largest one is really being able to talk about these issues with other people, and advocating for changes and awareness. That can go a really long way, and that's kind of your force multiplier. It's not just your actions, but then you can help engage other people in taking action as well.
Great, thanks for sharing, everyone. So right now, this is the end of the Q&A. We're going to spend some time, Sophie and I, to talk more about NYU and NYU Langone's health sustainability goals, and also to introduce the 2021 Sustainability and Healthcare Database. This image is no too surprise to everyone here already. This is the third time it's shown up during this event. Basically, for those who are not familiar with us, we are a large healthcare institution with over 13 million square feet of clinical, administrative, and research spaces. We have over 300 facilities in New York City and Long Island, and over 40,000 employees. So we are certainly a group that has a large impact and a very large footprint. So what many of these speakers have already touched upon today, at the end of the day, as a healthcare institution, we are contributing to the very issues we are treating. So therefore, we really have this moral imperative and mission as an anchor institution to address both of our impacts on the environment and to lead by example in changing healthcare delivery to address these threats to climate change. At NYU Langone Health, we have developed a set of strategies to reduce our own impact on the environment and increase efficiency, design better and more resiliency for the future. We teach the next generation of medical professionals how to deliver climate conscious healthcare. We advocate for broader change in the country and industry and build an overall culture within our organization. So this just becomes part of the way that we do business. As you see here, there are many different focus areas of our Green First sustainability program. These areas are driven by many different departments, teams, and professions. As we've heard today, sustainability solutions do not live with just one person or one area or one expertise. They are complex and often require collaborations across the organization. So what are some of these high-level goals that we are working towards? One of the most important goals is our 50% carbon reduction goal by 2025 as part of our participation in the New York City Carbon Challenge. We also participate in the Healthier Hospitals, Safer Chemicals Challenge, which eliminates certain chemicals of concern in our furniture and furnishings, cleaning products, hand soaps, and in many other areas where we purchase across the institution. And more recently, we've also joined the US Healthcare Climate Council, and we became the first and only New York City member hospital of this council. This was really an important hallmark for us because we took a leadership position nationally, and we now advocate for broader change related to healthcare sustainability alongside other top institutions. So this is kind of like a fun little slide just to show some stats that demonstrate the breadth and impact of our programs. For example, in 2019, we retrofitted over 20,000 LED bulbs to save energy. We deployed over 4,000 recycling bins to create a consistent and effective recycling program. We've installed 23 EV charging stations with dozens more along the way. And we've also purchased 57 gigawatt hours of green renewable energy credits to offset our electrical usage since 2015. We're also being recognized for some of these efforts by other leading organizations such as Healthcare Without Harm and Practice Green Health. We've earned over 45 environmental excellence awards since 2010. And more notably, if you've ever been to our main campus in Manhattan on 33rd Street, that's actually the only medical campus in the world to achieve both USGBC Peer and Lead Platinum certification. So I highly recommend to pay a visit if you're ever in the area. And that was a very quick synopsis of our program. I encourage you to look at our sustainability page on the website to learn a bit more about the program. But with all of that said, I am happy now to introduce Ryan Carney, who was our NYU Service Ambassador for the last year. He has been working on this incredible resource, educational resource, this database that I hope everyone here will have a chance to use and look at. Ryan?
Yeah. Hi, everyone. My name is Ryan Carney. I'm a sophomore majoring in global liberal studies and public policy, concentrating in sustainability, health, and environment. And so through my major, I became a service ambassador. And through that role, my project was to create a database that just features all the NYU Langone and NYU's publications on healthcare and sustainability. So the purpose of the database is just to illustrate the connection between health and environmental sustainability and how hospitals can demonstrate leadership and allow research to drive meaningful change in practice and care. And we hope that this will further your understanding of this connection and further your research and interest on these issues. The database features over 350 academic publications, which were compiled using a multitude of databases such as PubMed and NYU Scholars, and using 28 keywords to cover topic areas. So I'm going to share my screen now just to show you the database. So here it is. So right now, this is the cover page. It includes an introduction, just how to use it, and then, oh, there we go. And then just primary and secondary categories. The primary categories are the general topics such as food and transportation. And then the secondary categories are just those narrow down the topic further, because if you look at population, that's a very broad topic. So we wanted to make sure that you can narrow it down, such as air, chemical, general, and noise. And just keep in mind that these studies can fit in multiple categories, so you can play with the filters. And so the second sheet I can show you right now is just the list of all of the studies, publications. It's organized by primary, secondary, year, title, abstract, NYU Langone, NYU department. Researchers, the ones in bold are the NYU researchers. Publication, keywords, URL, and then citations. And then I can show you. So say you just want to look at food, you can just select it and it shows you all the food ones, and it shows you the secondary accessibility diet. Say you just want to look at pollution, you can just click pollution and then it shows you all of them. Then secondary category, you can just look at air, just say you want to look at air, and then it shows you all of the air ones. So it's just a way to filter out and narrow down your focus, and you can explore, have as much fun as you want, and try to find what you're looking for. You can organize it by year to find the most recent ones. So I hope this will be an educational resource and drive meaningful change in the practice. And then I will send the link to it. It's, if you go to the NYU Langone Sustainability website, it's right here. You click that link. It shows you this page with the PDF of all the different categories with the categories and the studies underneath. And if you click this, you can go to the Excel sheet and download it on your computer. So thank you. I look forward to any questions you may have or any feedback just to improve it, just the interface of it.
Great, thanks, Ryan. And I mean, I really have to commend Ryan here because he has spent hours searching through many, many different databases and with many search terms to kind of pull this list together. And it's not easy. So I really hope that everyone here will get a chance to take a look at it. Definitely reach out to us if you have any ideas of how this database could be used. We do plan on updating this every 2 or 3 years with new studies that NYU and NYU Langone Health comes out with. So with that said, we are coming to the end of our event. I would like to thank all of our speakers for spending time with us today. To our event partner, NYU Office of Sustainability, and of course, to all of you who are listening to us right now. I wish everybody a great rest of your day and a happy Earth Day. Thank you.